is a 65 years old female with a 1 month history of chest pain. She had diabetes, heart failure, and hypertension. Her coronary risk factors are hypertension, diabetes, and smoking. Her blood pressure and heart rate were normal at admission. Laboratory examinations showed elevated levels of blood glucose, total cholesterol, LDL, and BNP. An ECG shows a significant STT change. UCG showed left showed left ventricular ejection fraction is reduced 32 point. She was diagnosed as unstable angina pectoris, hypertension, heart failure, and rejection ejection fraction. Left coronary angiography shows LCX is dominant and 99% stenosis at proximal. And the left coronary angiography also showed moderate stenosis in the mid part of LAD. Right coronary angiography showed CTO of proximal RCA. LAD revealed many collaterals to RCA while the septal branches and the left ventricular apex. There are some collaterals to RCA while the septal branches. The QFR is 0.86 in the middle LAD. These patients underwent PCI into L6 with one stent 1 month ago. We can see there are some good collaterals to RCA where the septal branches. That's all. Thank you.
Okay, thank you, Professor Wang Tongyu. I think that we have a general idea about this patient. This is an old lady and with a relatively low body weight, over something 45 kilogram or something. And then we can see that it's a triple vessel disease. And 1 month ago, we finished the revascularization of circ. And this time we are focusing on the rest of the RCA occlusion. So maybe I give the rest of the time to Professor Jingling to give an introduction of the angiography for today and also the strategies of today.
Okay, good morning, everyone. Now let's see the first angiography. This is a patient of 3 vessel disease. We have complete revascularization of LCX last time. And this time we will focus on the RCA. And the patient's LAD, QFR value, LAD was 0.81. So we plan to defer LAD and work on ICA this time. Antegrade approach is the first choice in this case, since there is symmetrical channel by bilateral angiography. Contralateral collateral flow from septal to distal RCA is not close. Let's see this paragraph. The contralateral collateral flow from septal to distal RCA is not close. For antegrade approach, caroval microcatheter is my first choice. Now we see the next.
So we can see the stent in the circ is patent. And I noticed that we have implant IVP, right, for this lady.
This patient infection fraction is 32%.
Okay, so we have implant IVP for the left ventricular support.
Now we use caroval microcatheter and XT A
Okay, filter
first.
XTA, yes.
XTA first.
Okay.
Then we find in the proximal the XTA is punctured into the first lumen. So we change Gaia first.
Okay, so Professor Jing, I noticed that this is a relatively small lady with a relatively low body weight, and from the angiography and also the CT angiography before this procedure, we noticed some calcification, and this is a long diffuse lesion. So you just mentioned that for the antegrade approach, you tried the parallel technique and also the wire escalation technique. So could you give us some general introduction of your personal, how to say, experience, how to apply the wire escalation technique? Because you just mentioned you used fielder family wire and then switched to the Gaia first wire. Why do you perform these strategies? And is there any each point that we can learn from this approach?
Okay, this is a good question. We know guidewire uses strategy of antegrade wire escalation technique for CTO is important. We find that we use XTA is not puncture into the truth lumen, so we change XTA. For CTO lesions with tapered tip, it's recommended to start with a tapered tip design wire with a low to moderate perforation power, a polymer-coated guide wire. Some operations may be a customer to use a non-tapered tip polymer-coated guide wire, such as Pilot 50, which is also available strategy. If the initial guide where does not successful pass the occlusal segment, we will change the guide wire. But in this case, we use XTA and to Gaia 1 because we the first puncture into the first lumen, so we change the taper table guide wire.
Okay, thank you. So I noticed that after switching the, I think that Gaia first wire, it seems that it works very well. From the controllator angiography, it seems that the Gaia wire has been engaged into the distal true lumen. So what's our next step for this procedure?
Next time we will test the true lumen of this patient. So we'll use 1.0 blue to delicate to dilate this vessel.
Okay. So I noticed that you use a caravel microcatheter to try to use it as a support for the antegrade wire puncture and also switch it to the working horse wire. And okay, I think that this microcatheter or caravel has been pushed to the distal part of the RCA. So next you switch to a workhorse wire, right? This is seems to be a workhorse wire. So you just mentioned that you use a 1.0 balloon, right? It seems that you meet some resistance at the mid distal part of RCA, and from angiography and CTA, there is some calcification. So how did you perform this dilation using this small balloon? It seems that 1.0 balloon doesn't work, right?
First, we use 1.0 balloon to dilate this vessel, but we meet difficulty. So we change micro dilate balloon, 1.2 plus 12 to dilate this vessel. So we frequently to cross it.
Okay. So the 1.25 balloon is from Boston Scientific, maybe. It seems that the balloon diameter, 1.25 millimeter, is larger compared to the 1.0 millimeter, but the tip entry point of the balloon seems to be smaller with a tapered, as a tip, so it's relatively easy to get engaged. So let's see how did it work with a 1.25 balloon. Okay, this seems to be the 1.25 balloon, right, from the Boston. Yes, so it seems that passed through the lesion very smoothly. And also we make some dilation of the long diffuse stenosis. So maybe next we try, okay, this is the contralateral angiography and identify that the wire is in the true lumen at the distal part. So maybe next time we perform intravascular imaging to identify what it is like.
Next time we'll use EVERS to test it
Okay,
if it's a true lumen.
okay. So maybe some teach point need to be emphasized for this patient. Like I emphasized and Dr. Wang Tengyu introduced, this is a CHIP patient. It's a triple vessel disease. We notice that RCA is total occluded and circumflex is semi-occluded, and also that we performed PCI last time. And RAD, there is a focal made to severe stenosis. However, QFR indicated that RAD lesion could be deferred because it's only 0.8 something that is about the cutoff value. So that this time our target vessel is RCA. And for this kind of CHIP patient with a relatively, relatively old and small body weight lady, that is a potential high risk for PCI procedure complications. For example, the high bleeding risk, and also that we can see the ejection fraction value is only 30 or something. So before we touch this patient, we have IBP standby for this patient because we notice that its heart function is not that well. And IBP standby is of great importance for this patient because we noticed during the PCI procedure, we can see that the RCA guiding catheter is N plus left 1. After it's engaged to the RCA ostium, we notice that it seems to be deep engaged, and the blood pressure on the RCA guiding catheter is a little bit damped because the ostium seems to be severe, stenosis. So even though that is RCA, we should notice, pay attention to the blood pressure of the RCA very carefully. Another potential strategy for this procedure, I think that is a retrograde approach because we know it's a relatively very long diffuse lesion, and there are two segments occluded for the RCA. One is at the proximal part, one is at the mid-distal part. So that if the antegrade approach failed, I think that the retrograde approach is a potential strategy for this patient.
Okay.
So we notice some potential, intimal dissection, maybe due to the dilation. So we try not to perform antegrade angio anymore. Okay. It seems the balloon opens very well. Here's some superficial calcification, but not so severe. Okay. Maybe higher is fine because yes, the proximal part is okay. There is no negative remodiving. And you notice that we are using a guiding catheter, not an angio, catheter for the left coronary artery. And also there is a wire in the circumflex with a potential support and backup for the potential risk factors if something, for example, happens in the left coronary artery. So a wire in the circumflex, in this case, is a potential very important information. Okay, now we are using the 2.5 cutting balloon for this case. I think that for the plaque modification for the CTO lesions is about potential very important information because we need to make the plaque dissection in a controlled situation. Also, the plaque should be longitudinally distributed to help the potential, upcoming stent expansion. And also we notice that the stent expansion is of key importance for the prognosis of the patient. Okay, once again, we notice that after the vasodilator and also the cutting balloon, we can see that the distal landing zone seems to be much better now. So this is, like I said, for the CTO lesions, after the initial, recanalization, sometimes that the vessel size doesn't seem to be at the right situation. So vasodilator and give some time for the artery to get away from the spasm situation due to the long time occluded situation. So it's very of key importance. this is very important for us to choose the right size of the stent. Otherwise, that potential relatively small stent size is of a potential high risk for stent anterior expansion. So this is attenuated plaque. It's called the seesaw wire balloon cutting technique. It's very special. After the first guidewire has passed through the lesion successfully, and the other devices, for example, the 1.0 balloon and the other devices cannot pass.
Okay.
We can try to use the second wire to send along with the first wire as a landmark through the CTO segment, and use two small caliber, balloons to dilate the CTO segment one by one. First, we use the first one to dilate, and we draw back the balloon, and the second balloon on the other wire got engaged and dilates the whole lesion. And with this seesaw wire balloon cutting, it's a potential very good advantage and the choice in passing through the CTO segment that cannot be passed. Okay, so maybe we'll perform NC balloon dilation first to see the situation. So like I said, and also our information from the CT angiography and also the bilateral angiography, we can see that it's a long diffuse lesion with calcification, and the plaque burden is relatively very high.
14, 16. Okay, done. 16,
可以。
18. Done. 16, 18, 20. Okay, done. 16.
Okay, this is a 2.5 NC balloon that we are going to dilate the stent with a relatively high atmosphere, because we can see the plaque burden is high and the stent is not well expanded after the initial stent deployment. And for this patient, we have performed revascularization of the circ and also the RCA. The LED QFR indicated can be deferred for some time, so that we have finished full revascularization. This is a good promise to the prognosis of the patient, especially for this small lady. I think that CABG for this patient is of a potential high risk. This is a 275 NC balloon.
16, 18. Done. 18, 20, 22. Deflation.
And the primary manuscript indicated that the full revascularization, like this one, is of a good promise to the prognosis. And I noticed that there is a question from the audience online that's asking whether we have some made in China microcatheters, which is the devices that manipulate in China. Yes, we have. One of the microcatheters that is of a potential good use that is made in China is called the instant pass that is made by China by the Huitai, a medical product company in China. It's of several designs in the clinical application. For example, we have the 1.7 French microcatheter, the 1.9 French microcatheter, and also the tapered design like the Corsair with a 2.6 French microcatheter. So we have some very good microcatheters made in China. And last time, I think Professor Li has made a demonstration of these devices. For the Caravel microcatheter, I think that some audience is very interested in it. The Caravel microcatheter is of a potential, low profile and associated with a large lumen of this microcatheter. So the outer profile is small. And also the tape is relatively very tapered. The tip length is 5.0 millimeter, and the entry profile is only 0.5 millimeter, 1.4 French. Okay, I think that is the stent to cover the osmium of the RCA. So we can see that the stent is not well localized Okay, after the wire has been floating in the aorta of the RCA, we can see that the guiding catheter is stabilized a lot better compared to the previous situation.